viewers.
YouTube, I said.
Baidu, you unmute yourself and you can start.
Yeah. Good evening, everyone. Welcome to Neboy Classroom. Salivary glands have always fascinated all of us, all ENT, head and neck, and all general surgeons. And is today's classroom. Our focus shall be on this topic of common interest to all of us. The speaker is Dr. Manas Pratim Das, who is a senior resident at Silchar Medical College and Hospital, and the session will be moderated by Dr. Ashok Das, a leading head and neck surgeon with vast oncological experience. Incidentally, both of them have completed their postgraduate studies during my days in medical college as faculty and teacher. Manas was known as a sincere student and has shaped up as a good ENT surgeon. Dr. Ashok Das, an alumni of Guwahati Medical College, completed MS in the year 2003. He did fellowship in head and neck surgery from Tata Memorial Hospital, Mumbai in 2003 and 2004. Apart from this, he did Indo-American Cancer Fellowship at Memorial Sloan Kettering Cancer Center, New York in 2017. Currently, he is the professor in the Department of Head and Neck Surgery at Biborwa Cancer Institute. Also officer in charge of Clinical Research Secretariat at BBCI. He has 36 number of publications in local, national and international journals. He is the principal investigator and co-principal investigator in 10 multicentric research study and clinical trial. Now I invite Dr. Ashok Das to kindly take over further proceedings. Dr. Ashok Das, please.
Thank you, madam. And good evening, everybody. Nice to be among all our people again. So without wasting much time, I would like to invite Manos to start his presentations. And just to start with, we all do parotid surgery. So it will be needless to say that we will, but we have discussed yesterday, Manos and me, that there are few gray areas which we will discuss. So let's first finish his presentation, then we'll come to this. Manos, please start. And requesting all to mute everybody so that we can hear Manos properly.
Good evening to everyone present in the webinar today. I'm Dr. Manas Pratim Das. I'm a fellow in State Cancer Institute, and I'm also doing my residency at Silchar Medical College. So today our discussion will be on salivary gland neoplasms. So the salivary gland neoplasm discussion will be on the management strategies. Like sir has already said that there are certain gray areas, and I'll focus on that. And this will also be an overview on the general outline. So this is the plan of the discussion for today. So mainly I'll be focusing on the diagnostic dilemmas that we surgeons as well as the pathologists face because of a wide variety of tumors that are present in the salivary glands, and also in the management part. The management, although we know that it is mainly surgical, there are certain areas where only surgery is not sufficient, or the extent of surgery has to be known when and where we have to address the neck. and where adjuvant therapy is necessary. So we'll start the discussion. So as we all know that salivary glands are a rare entity. It constitutes around 3 to 6% of head and neck tumors, but it is challenging for the pathologist often a lot to come to a definite diagnosis. The behavior of the tumor is different according to the pathology. Some are aggressive, while others have a long and protracted course, only to appear after a period of uh, no clinical manifestation. So it is important that we understand the disease pathology and its natural history so that we can appropriately devise a treatment strategy. And nowadays, newer molecular techniques have come which help us in this process. So neoplasms of the salivary gland as a whole, it is around 3 to 6% of tumors of head and neck region. So who are at risk? Females are affected slightly more than males, except in case of Warthin's tumors, which is predominantly in males. All the ages are susceptible. However, the peak is at around 60 years of age. Now, what are the risk factors? Low dose radiation exposure is known to be a risk factor for salivary gland neoplasms. So, tobacco smoking, and also there is a Epstein-Barr virus infection in case of Warthin's tumor. Nowadays, it is also said that using telecommunication devices like mobile phones also increases the risk of neoplasms of the salivary gland. So these are some of the common salivary gland tumors. The most common salivary gland tumor, which is a benign one, is the pleomorphic adenoma. Pleomorphic adenoma is said because it has components from epithelial, from myoepithelial, as well as stromal elements. So this tumor is known for its tendency to recur. It also has a chance of malignant transformation in the long run, and that is why it's important. Warthin's tumor is more predominant in the males, and it is found mostly in the parotid gland. These are uh, these the cells of Warthin's tumor have high concentration of mitochondria, and as a result, they they are found in PET scan to be taking more uptake. Other benign tumors we should be aware of are oncocytoma and monomorphic adenomas. Common malignant salivary tumors are mucoepidermoid carcinoma, adenoid cystic carcinoma, acinic cell carcinoma, polymorphous low-grade adenocarcinoma, adenocarcinoma not otherwise specified, squamous cell carcinoma, and carcinoma X pleomorphic adenoma, and salivary ductal carcinoma. Now, these malignant tumors are of different grades. Like mucoepidermoid carcinoma, if we see, it has three different grades, and this grade will determine the clinical behavior of the tumor. Adenoid cystic carcinoma, in general, although it has got grade, it is considered to be a aggressive tumor. Adenoid cystic carcinoma has a high incidence of perineural invasion, and although it has got a disease, protracted course, it has chance of metastasis to the lungs. Acinic cell carcinoma in general is said to be having indolent course, although a high grade form is also known. Uh, polymorphic low grade adenocarcinoma is a low grade cancer. Adenocarcinoma not otherwise specified, squamous cell carcinoma, these are high grade. Salivary ductal carcinoma is a very aggressive tumor, and carcinoma X pleomorphic adenoma, it it develops as a malignant change in a pleomorphic adenoma over long course of time. So the type of tumor, the type of malignancy or aggressiveness, it varies with the histology of the carcinoma. So if you see the distribution of common tumors, we see that most of the neoplasms, they occur in the parotid, and lesser occurs in the submandibular glands. However, if we see that as the size of the gland decreases, the more chances are that they will be malignant. So parotid has around 80% chance of 80% benign tumors and 20% malignant. Submandibular gland has around 60% benign and 40% malignant. And in minor salivary glands, it is around 80% malignant. And if we see the distribution of malignant tumors among the different glands, we see that mucoepidermoid carcinoma is commonest in the parotid gland. The adenoid cystic is common in the submandibular and minor salivary glands. Adenocarcinoma is common in the minor salivary glands. And among the different sites of the minor salivary glands, it is the hard palate which is the most common site of occurrence. Other sites are tongue, cheek, and maxillary sinuses and nasal cavity. So a little bit about the embryology, if we see that this salivary gland, they develop as outpouching of oral ectoderm into the surrounding mesenchyme. So interestingly, if we see that in the parotid, it grows from anteriorly in a posterior direction, and as a result of which it encompasses or surrounds the facial nerve as it and advances anteriorly. And also we should keep in mind that parotid gland, although it is the first among the major salivary gland to develop, it is the last to become encapsulated. And as a result of that, lymphatic tissue often gets entrapped within the parenchyma of the salivary gland. So we see many a times that there are intraparotid lymph nodes uh, which are metastatic from other sites, other primary sites, and also Warthin's tumor, which develops in the parotid gland, is because of presence of those lymphatic tissue in and around the parotid. So this is a slide on the histology of the salivary gland. So if you see that there are uh, this acini mucus and serous acini, which are surrounded by myoepithelial cells, and they will drain into the intercalated ducts. The intercalated ducts will unite and they will drain into the intralobular, and finally they will drain into the excretory duct. So the histology is important because different types of tumor, they arise from different parts of the salivary gland. There are basically two theories of tumorigenesis of salivary glands. There is a multicellular theory which says that the cells, they become de-differentiated from differentiated cells, and there is the more accepted theory is the reserved cell theory, which says that the differentiated cells, because of faulty differentiation, they acquire neoplastic properties. So adenoid cystic carcinoma, acinic cell carcinoma, adenocarcinoma not otherwise specified, malignant mixed tumors, and then oncocytic tumors, they are said to develop from intercalated duct reserve cells. And mucoepidermoid carcinoma, salivary ductal carcinoma, they are said to develop from the excretory duct reserve cells. Now, this is important for all of us. How does a patient with a salivary gland neoplasm present to us? So, most common presentation is that they will come with a lesion, with a swelling in the region of the said or affected salivary gland. So, this swelling, if it is in the parotid region, they will come as a swelling in the region of the cheek, right behind the mandible and the ear. If it is in the submandibular region, then it might be from the submandibular gland. If it is a deep lobe tumor, then it might push the uh, pharyngeal contents, the tonsils medially, and so on. Important thing we should remember are that this swelling is a common presentation, but if certain clinical features are associated with the swelling, then we have to suspect that the swelling may be a malignant one. So if the patient comes to us with a pain or paresthesia, if there is a history of rapid growth, if there is history of nerve involvement, so more commonly it is the facial nerve in case of parotid gland, if there is skin involvement, if there is irregularity of the swelling, or if there is fixicity to the adjacent structures, the chances are that the tumor might be malignant. And also we should keep in mind that smaller the gland, the chances of its being malignant is more. Now, here comes the one of the important gray areas that we should be discussing around is that how do we come to a diagnosis of the salivary tumors? So before going into details, I want to tell 2 or 3 points about the difficulties. So WHO has recently classified salivary gland, and there are around 24 or 25 malignant and a wide variety of uh, benign tumors. So there is a difficulty for the pathologist to specifically come to a diagnosis preoperatively. Also important is that the benign and malignant varieties of tumors, they have similar appearance on FNAC. Say for example, basal cell adenoma and solid variety of adenoid cystic carcinoma, they look quite similar. Also, if a patient has a pleomorphic adenoma and a FNAC is taken, and another patient has a carcinoma ex pleomorphic adenoma, but the FNAC is taken from the benign part, so it might come out to be a benign, although actually those are malignant tumors. And lastly, there is this grading. So different salivary glands tumors are graded differently according to their aggressiveness, and this has to be kept in mind for the pathologists as well as the surgeons, that we do not undermine the type of tumor that we are dealing with, because certain tumors are very aggressive while others are having a indolent course. So I'll come back to the slide now. So the diagnosis is mainly a cytology-based diagnosis. We prefer FNAC over a true cut biopsy unless it is necessary, absolutely. FNAC is quick and reliable, and it is more than 95% accurate in experienced hands. So, and using an ultrasound guided biopsy, it increases the specificity also. So it is said that FNACs had 96% overall diagnosis accuracy in distinguishing benign from a malignant parotid tumors. Using an ultrasound also helps differentiate it from other similar swelling, like a node from a salivary gland, etc. When do we need to use a core biopsy? Now, core biopsy is a more invasive procedure. It needs local anesthesia. It is painful, and there is a chance of temporary facial nerve injury. So it is used only when there is a equivocal FNAC on diagnosis, if we suspect lymphoid malignancy, or if we require immunohistochemistry for further use in our treatment. So this is the WHO histological classification of tumors. So around 24 or 25 malignant epithelial tumors and a wide variety of benign soft tissue tumors and hematolymphoid tumors are there. So this is one of the reasons that it is difficult for the pathologist to come exactly to a pinpoint diagnosis the very first time. And this is what I was telling about the grading. So grading is a histopathological surrogate that will determine the aggressiveness of tumor. And although it is graded into three types, the tumors are graded into three types: low grade, intermediate grade, and high grade. For all practical purposes, the intermediate grade is considered or taken as a high grade for safety. So what are the low grade tumors that we should remember? These are the acinic cell carcinoma, polymorphous low-grade adenocarcinoma, and low-grade mucoepidermoid carcinoma. Other than that, the others should be considered as high grade. And more importantly, it is the high-grade mucoepidermoid carcinoma, salivary ductal carcinoma, carcinoma ex pleomorphic adenoma, and adenocarcinoma not otherwise specified. And this is important thing, that what are the unique pathological issues that are faced or that should be addressed while addressing a certain histological type. In the mucoepidermoid carcinoma, it has got three grades. So the intermediate and high grade are relatively aggressive, and so the grade should be addressed. Adenoid cystic carcinoma, although grade is mentioned out here, it is generally considered to be a aggressive tumor. Carcinoma X pleomorphic adenoma. This has got the carcinoma in a pleomorphic adenoma can be of different histological types, and so the specific histological type, the grade, and the extent of invasion should be addressed. Myoepithelial carcinoma, basal cell adenocarcinoma, adenocarcinoma not otherwise specified, acinic cell carcinoma also, the grade should be mentioned. Specifically, acinic cell carcinoma, it is a less aggressive tumor. However, there is a 10 to 15% chance that a high grade or aggressive variety might be there. Now, small cell carcinoma and squamous cell carcinoma. Small cell carcinoma, as we know that these are neuroectodermal tumors, and it should be determined whether it is a primarily arising in the salivary glands or it is a metastasis, especially from the lungs. The metastatic small cell carcinomas have like carcinoma, small cell carcinoma arising in salivary gland are said to have better prognosis than the metastatic ones. And squamous cell carcinoma, it should also be differentiated whether it is a primarily arising in the salivary gland or it is a metastasis from head and neck or other side. In case of lymphoma, FNAC will not suffice, and there is a need of tissue biopsy through a true cut biopsy after FNA diagnosis. And in all carcinomas, we should look for high grade transformation if it is there or not. So one part of diagnosis is cytology, the other part is imaging. So imaging is necessary not only to diagnose via guided FNEC or biopsy, and it is also necessary to look to distinguish from other structures, adjacent structures, also to know the extent and invasion into adjacent structures. So ultrasound is an inexpensive method of imaging, and small tumors located in superficial lobe of parotid can be detected very easily, and it can be also used for FNEC or guided biopsy. And ultrasound also helps to distinguish lymph nodes from salivary tissues. More importantly, the role of cross-sectional imaging in salivary tumors. Now, cross-sectional imaging comprises both of MRI and CT scan, and nowadays there is PET-CT scan also. So, MRI is slightly more preferred than CT scan in salivary tumors. So, when do we need a cross-sectional imaging in salivary tumors? So, when the tumor is more than 4 centimeter size, when the deep lobe of parotid tumor is involved, or there is a parapharyngeal space tumor, when we are suspecting malignancy on the basis of clinical findings, like there is limited mobility of tumor, there is involvement of the facial nerve, there are cervical lymph nodes. So at that point, cross-sectional imaging comes into play. It helps us to know the extent of the tumor, invasion into the surrounding structures, if there is a perineural invasion. In cases of residual and recurrent disease also, cross-sectional imaging is helpful. Certain features in MRI which helps in knowing whether it is malignancy or not is that if we find a T2 hypointensity, if we see irregular margins of the tumor, if there is a low signal on diffusion weighted imaging, and if there are features of local invasion, then probably the tumor has a chance of turning out malignant. Now, before we go specifically into the management of the salivary tumor, we should know that there are certain features which make the tumor having adverse prognosis also. And preoperatively, that can be determined by looking at the size of the tumor. If it is a high T stage tumor like T3 or T4, if there is involvement of the facial nerve in the form of facial palsy preoperatively, if clinically there are neck nodes palpable, if the FNA shows the tumor to be a high grade tumor, or the imaging shows or clinically we find that there is extraglandular extension, and if it is occurring in a older age patient, 60 years or more, then probably this tumor will behave aggressively and has to be dealt with as such. And sometimes these features may not be present preoperatively, but postoperatively in the histopathology, we find features like positive surgical margins, there is perineural invasion or lymphovascular invasion, the grading is high histological grading, pathologically the neck nodes come out to be positive, or there is expression of high expression of Ki67 and low P27 in acinic in adenocystic carcinoma and mucoepidermoid carcinoma. So preoperatively, if we find these features, already we can think that the tumor will behave in an aggressive manner. And even if we miss, even if these features are not present preoperatively and postoperatively, we come to find out the other histopathological features, then we have to treat the neoplasm, the malignancy, as a aggressive one. So this is the recent TNM staging of salivary gland tumor. This is applicable for major salivary gland tumor. The minor salivary gland tumors are staged according to the subsite they are present. So nose and paranasal sinus will be staged as a nose and paranasal sinus carcinoma. Larynx and hypopharynx will be done accordingly. An oral cavity minor salivary gland tumor will be staged as such. So come to the management of salivary gland neoplasms. Now, in case of salivary gland neoplasms, whenever the tumor is resectable and if in case of recurrence also, if it is limited, upfront surgery is the treatment of choice. Radiotherapy has a role mainly in the adjuvant setting. Radical radiotherapy has lesser role, and there is also this thing called re-irradiation. Chemotherapy also can be used as a part of adjuvant or radical treatment with radiotherapy or in the palliative setting, and there are targeted therapies. So this is a treatment algorithm that I just made by myself after coming through different texts. So a salivary gland neoplasm, after diagnosis, we go for a cytology and imaging, and after correlating all the features, if it is a benign tumor and if indicated, surgery is done, and after post-op evaluation of the HPE, if it turns out to be a benign tumor, we follow up the patient as in any other benign conditions. However, if the post-op HPE is a malignant one, we treat it as a malignant tumor. Now, for malignant tumors, we look for these things. If all of the low risk features mentioned are present, then we treat it as a low risk malignancy. And if any of the features present in the high risk category are present, then the tumor is treated more aggressively. Now, if the disease is a T1 or T2 disease, or a low grade disease, and clinically the neck is not involved, we go for surgery, upfront surgery to the primary. For the neck, we can do elective neck dissection in all the cases, or we can go for a frozen and we can proceed to a comprehensive neck dissection if the nodes come positive. Or the third option is that we wait for a post-op HPE, and if it comes out to be a high grade or there is neck node positive, then we can irradiate the neck along with the primary. Now, in the other category, if any of the high risk features are present, say for example, if the tumor is a T3 or T4, or it is a high grade tumor, or clinically the neck is involved, then we can go as following. If there is a clinical neck node positive, then we have to go for surgery along with a neck dissection. If with the high risk features, the clinically neck is not involved, then we go for surgery to the primary. And in neck, we go for elective neck dissection level 2, 3, 4, or elective neck irradiation, or as previously stated, we go for frozen biopsy and proceed. Now, when do we go for a post-op radiotherapy to the neck? If pathologically neck nodes are positive, and further I'll discuss if any adverse features are present in primary tumor. So the extent of surgery for salivary neoplasms, uh, in parotid gland neoplasms, as we all know, we can go for a superficial parotidectomy, which is the excision of the part of the salivary gland, which is lateral to the facial nerve. Adequate parotidectomy is one where we remove the tumor with an adequate cuff of normal tissue around the tumor. Then there is extracapsular dissection. Uh, Another one is total conservative parotidectomy with preservation of the facial nerve. This is done when there is involvement of the deeper lobe of the parotid. A total parotidectomy with excision of the facial nerve. I'll come to the conditions when a facial nerve has to be sacrificed. And there is total radical parotidectomy. And if there is more extensive structures involved, like the external auditory canal, etc., those may also have to be removed. In case of submandibular gland neoplasms, tumors, we have to go for excision of the submandibular gland along with elective neck dissection. Sublingual gland tumors have to be resected and blocked, and minor salivary glands has to be removed depending on the site and accessibility of the tumors. Now, in parotid surgeries, one of the critical issues is the management of facial nerve. So, facial nerve palsy, as we all know, has a negative impact on the psychology of the patient and the quality of life. And that is why a thorough surgical anatomy knowledge has to be there, and adequate surgical skill on the part of the surgeon has to be present. Nowadays, facial monitoring intraoperatively has become a norm. So, when do we go for uh, sacrifice of the facial nerve? If there is preoperatively facial nerve palsy, and number two, intraoperatively we find that the nerve is grossly involved by the tumor and we cannot manage to save the facial nerve. Now, another topic of importance is that when should we address the neck in salivary gland malignancies? Now, clinically, if there is a neck node present, so we have to go for a comprehensive neck dissection. Now, in cases where there is no neck node, but the primary is T3 or higher, or the histopath of the tumor is a high-grade malignancy, or there is perineural invasion or facial palsy, etc. So we should go for a elective neck dissection, which will be from at least from levels 2 to 4. And after a after a positive frozen section of the sentinel node, we can go for a comprehensive neck dissection. So in cases of elective neck dissection, at least levels 2, 3, and 4 should be addressed. Now, frozen section analysis is important in certain conditions. If there is an inconclusive FNAC of the nodes, if the sentinel node biopsy in clinical neck, uh, no clinical N0 neck before proceeding to a comprehensive neck dissection, and more importantly, in cases of nerve involvement, we should look until we get the negative margins. Now, role of radiotherapy. Now, radiotherapy in cases of salivary gland have got more important role in a adjuvant setting than the radical setting. And nowadays, a new concept has come, which is re-radiation. Now, in re-radiation, we irradiate same area or a similar or a area of overlap of 50% or more to compared to the previous area of irradiation in recurrent disease or in a second primary cancer which is occurring in a previous irradiated field. Adjuvant radiotherapy is indicated when post-operatively we find out that there is advanced stage, there is positive margin, there is high-grade histopathology, there is local tissue invasion in the form of adjacent tissue or nerve involvement, or pathologically the neck node has come out to be positive. Radical radiotherapy, as such, it is said to be inferior to surgical treatment. However, radical radiotherapy is indicated in patients who have unresectable tumors or the patient is unfit for surgery or unwilling to go for surgery. These are all for malignancies of the salivary gland. Now, chemotherapy is used with a curative intent with radiotherapy in adjuvant setting, and in the palliative setting, chemotherapy can be used alone. So it is used in the palliative setting for patients who are not candidate for radiation or surgery and for metastasis or locally advanced and unresectable tumor. And nowadays, molecular target therapies have come into play. So there are clinical trials using the targeted therapy. These are restricted at best to phase 2 trials, and the targeted therapies so far has not shown any convincing anti-tumor activity. Some of the targeted therapies that are used are in adenoid cystic carcinoma, we use imatinib against c-KIT. In salivary ductal carcinoma, we use trastuzumab and lapatinib against HER2 receptor. So in actinic cell carcinoma, if it expresses VEGF family of receptors, so exenatide is used, so on. Now, management of a metastatic or recurrent cancer. So salvage surgery can be done only with limited local or regional recurrences. And if salvage cannot be done, these are cases for palliative chemotherapy. Now, adenoid cystic carcinoma is known for metastasis. Although it is got a slow course, there is evidence that there are lung metastases in adenoid cystic carcinoma. So, how do we follow up a patient after initial treatment? So, follow-up of patient is necessary because approximately 80 to 90% of recurrences, they occur within the first 2 to 4 years. So conventionally, it is said that for the first year, we should follow up the patient every 1 to 3 monthly. For the second year, in the second year, they should be followed up every 2 to 6 monthly. For the years 3 to 5, they should be followed up every 4 to 8 months, and then forward yearly, or if new symptoms come. So adenoid cystic carcinoma, lifelong follow-up has to be done because they have got a chance of delayed recurrence. Now in the follow-up, imaging has got role in assessing different difficult areas like skull base or in surgical beds which are obscured by flaps. There is a limited role of PET CT scan in routine follow-up of salivary gland neoplasms after treatment. So, what are the prognostic factors that we should look if the tumor is a high-grade tumor, if the patient has a metastatic neck node, if there is soft tissue invasion in the form of perineural or lymphovascular invasion, if there, we should also look at the radicality of the resection if the margins have come to be positive. And finally, this is an interesting thing that minor salivary gland tumors arising in the nose and paranasal sinus have a bad prognosis. This is because of two reasons. The minor salivary gland in nose and paranasal sinuses, they manifest little bit late after there is deeper invasion. And secondly, it is the radicality of the resection. Sometimes because they present late and there is already invasion into areas which cannot be resected, the prognosis becomes bad. Now, what are the complications that we face? Specifically, we all know that in parotid, the facial nerve is one of the most critical structures which has to be preserved, and neuropraxia or nerve injury can occur commonly, and the thorough anatomy of the facial nerve is necessary. Knowledge of the anatomy of facial nerve is necessary so that we are able to preserve the facial nerve. Then freeze syndrome occurs, paresthesia may occur, hematoma or salivary fistula occurs late, and stump neuroma in the form of greater auricular nerve resection also happens. In the submandibular gland, nerve pulse is mainly we have to take care of the marginal mandibular nerve, the lingual nerve, and the hypoglossal nerve, which is found around the bed of the submandibular gland. There are also complications related to radiotherapy, mucositis, skin ulceration, hair loss, then osteoradionecrosis of the mandible and temporal bone, cerebral radionecrosis and fibrosis can occur, hearing loss, and xerostomia. So, coming to the end of the presentation, so salivary gland neoplasms are rare, but these are challenging entity for head and neck and the ENT surgeon. They give a hard time to the pathologist, and these tumors can have different clinical behavior based on the histology and grading. So certain prognostic factors are highly reliable and gives a good picture of the management as well as the outcome. Surgical expertise for surgeons is utmost important because the complications that can arise as a result of lack of knowledge of anatomy or skill are unforgiving. Management of the neck is important, and there is not one standard policy, and there are newer targeted therapies which are evolving, but still their presence uh, has still to make a mark. So that is all, sir and madam. Thank you.
Yeah. Thank you, Manos.
Yeah.
Can you just stop sharing the screen so that we can see everybody's face? Yeah. Stop sharing.
Just a second, sir.
Done. Yeah. So Manos, I would like to congratulate you. Really taking hold this presentation as a classroom. It's really it looked like sitting in a class. Very nice, very comprehensive, very simple way. Um, uh, I, so all our teachers are here, but before we hear from our teachers and the experienced surgeons like Amit sir and all, Fukan sir. So I would like to invite few queries or comments from our young audience here in this forum. Yes, Manas, you are ready to take up questions?
Yes, sir.
Yes, sir. So is there any question in the chat box? Let me check. Okay, everybody is congratulating only Manas. So there is one question from Fukan sir, that adequate periodictomy can done only in tail of parotid tumor. Is it so, Manas? What is
Sir,
your
sir,
adequate periodictomy? Is it
yes, sir.
only?
Sir, adequate parathyrectomy, sir. There is extracapsular dissection, sir. So, so extracapsular dissection we do until in extracapsular we do not look directly for the facial nerve, but
Okay.
we try.
Manas, can you just define very shortly what is a adequate periodictomy is?
Sir, in adequate parathyrectomy, sir, we remove the tumor along with a cup of the tissue around it, and we do not go into looking for the facial nerve.
Right. So, but most of these tumors are usually located at the tail of the parotid. Is very true. Another question from Pugan sir is that from core biopsy lymphoma can be diagnosed or true cut necessary. You understand, na? So when we suspect a lymphoma, we need tissue to do immunohistochemistry. So is true cut and core biopsy means core biopsy is basically done with a true cut. Am I right? True cut needle.
Basically, I was same sir. These are similar procedures. So we obtain a good amount of tissue, which will help us to give a tissue diagnosis, not just a cytological diagnosis.
Yes. So let me check. Is there any more tumor? Yes. So Kalpana ma'am asks, what about multifocal and bilateral tumor? It's related to what I exactly forgot. Might be at some point of time we have these questions. Okay. There is no more questions. So let me ask you a few things, or rather to discuss with you, Manas, and we'll take comments from our seniors and experienced surgeons. So, what is the role of imaging, Manos, particularly a very small palpable tumor at the tail of the parotid, which come in your hand, and how this, whether you say ultrasound or CT scan, will change the treatment decision.
So in a
Basically, I
small
want to
tumor,
know, right, very small tumor or suppose a pleomorphic adenoma, they are in the tail parotid. So, do you require any investigation, any imaging for that?
definitely we do not require a cross-sectional imaging in that situation.
Right.
Uh, yes, sir. Uh, Ultrasound may be able to differentiate it from a intraparotid lymph node.
Yeah. As sometimes as because it is multifocal, so we need to rule out any pathology in the deeper part of the lobe. Am I right? So that is one indication I feel. And second is regarding FNSA. So I just think the thing little differently, Manas, as because there are almost some 40 odd salivary tumor according to the latest WHO report and whatever you have shown. So just talk about the common tumor in the parotid. Is it because it is common, or is it because the pathologists are more acquainted with a small group of
Yes, sir. Yes, sir.
parotid tumor? Because even I cannot tell you more than one third of salivary tumor of hold this long list until and unless I open up the book. So for a lot of pathologists to give that kind of diagnosis, it's mere impossible thing. So is it because they accustomed to very few pathologists, and that is why this incidence is very high in some a few of this particular tumor, or it is other way? What do you think? I'll take opinion from our experienced teachers and surgeons regarding this point, because for parotid, we are only seeing few pathologies mostly, you see, either pleomorphic or mucoepidermoid or, ACC. So is it really so, or it is some fallacy with the pathologist? But I'm sorry to just putting a debatable thing.
Yes, sir. This has been given in text also that because the pathologists see more of certain tumors, they are biased, or they are more likely to give a diagnosis of those commoner tumors than the rarer ones. So,
Yes. Before I go to our seniors for comment, one last thing I want to ask you. Uh, as a surgeon to do parotid surgery, mostly we are concerned about the facial nerve. Am I right? So, for any
sir,
accidental
I'm not
case,
getting it.
I'm sorry. Can you hear me?
Yes, sir. Can
Yeah.
you repeat, sir?
Yeah. So, as a surgeon, basically we are concerned during parotid surgery for identifying and preserving the facial nerve. Am I right?
Yes,
So,
sir.
I just wanted to ask you, suppose if there is any accidental damage or cut in the facial nerve, so can we re-anastomose,
Yes, sir.
or can we put a graph, and what are the results, or what is the best time to reconstruct the facial nerve? And last thing to add with that, does adjuvant treatment like radiotherapy have any detrimental role in facial nerve regeneration?
Okay. So the last part, I will not be able to say, sir, whether or not adjuvant radiotherapy has a detrimental role. Uh,
Okay,
but
let's start the first phase. Suppose if you cut by
yes, sir.
accident, there is damage to the facial nerve, will you re-anastomose or what? Will not you try to re-anastomose the nerve?
It is said that re-anastomosis, if whenever identified, sir, we should try to re-anastomosis it at that point of time only. If if there is a segment loss of the facial nerve, then we can take a segment from the greater auricular nerve, which is present in the adjacent area only. Sir.
Great, very nice, Manas. So I would like to invite few comments from our teachers and most experienced surgeons. Amit sir, Swagata madam, and Kalpana ma'am is also here. Mukherjee sir, you please have some comment, or if you want to.
Hello. I
Yes,
think the
sir.
presentation is very good. He has told everything in a very concise way. And I congratulate it really for the nice presentation. Thank you.
Thank you, sir.
Yes, Manas, you did really very well. And it's like a classroom teacher, real classroom. And you have covered everything of the subjects. So very good. I think with us, Dr. Kudus Hamid, he can highlight some of the important points of
Yes,
the,
yes, ma'am. I'd like to
yeah,
request
yeah.
Amit sir
We'd like to hear
for his
from
comment.
Dr. Kudus
Uh,
Hamid. Yeah.
I think you have presented very well. I think very systematically, and you've covered most of the important things. So, about FNAC, the FNAC, it's okay if it's a superficially located tumor, but in general, I would prefer to do a guided FNAC wherever possible, because as Dr. Ashok Das has pointed out, sometimes we may miss some tumors which may be lying a little deeper in the tissue. So maybe that's one area where a guided FNAC, not only in the parotid but anywhere in the neck, I would prefer guided FNAC to be done. And another thing about the incidence of salivary gland tumors, all kind of salivary gland tumors considered, the parotid, as you have rightly mentioned, constitutes about 80% of all salivary gland tumors. And there is one old dictum which says is a what is known as the 80-20 rule.
Yes.
So the 80-20 rule essentially means that this 80% of salivary gland tumors occur in the parotid. That is one. Then 80% of parotid tumors are benign. 20% are malignant. Then these are not absolute figures, but these are relative or easy to remember figures whenever you don't remember when you are asked in an examination. So if you remember the 80-20 rule, the parotid is 80% benign, 20% malignant. Then the submandibular, it is rightly 60% benign and 40% malignant. But then an easier way to remember is approximately half of them will be maybe malignant.
Yes.
That is one. Okay, and in the minor salivary glands, it is 20% benign, 80% malignant.
80%.
These are all approximations. But when you come to the sublingual gland tumors, they are very rare. Say maybe about less than 5% of all salivary gland tumors, but they are on the flip side about 95% or more of them are malignant. Figures are very small. Sublingual, how many tumors do you see? So, but this is an approximation which some of the older generation surgeons have put forward for us. So it's and just an easy way to remember the incidences of these salivary tumors. Then, of course, molecular biology, you have mentioned about molecular biology. These are still evolving and probably will take some time before we can really utilize this molecular markers
Yes,
in clinical practice. Yeah, I suppose that would be some of the things I would like to put before you. And thank you for
Sir,
for the very nice presentation.
Sir, before you leave, this thing for me regarding facial nerve reconstruction. What is your experience on that?
Reconstruction, well, we have not had to do many reconstructions, but whenever feasible, as Manas has already pointed out,
Right.
primary reconstruction should always be aimed for. And the results is very difficult to really predict, but there are reports that primary repair is a much better thing, because later on, if you want to reconstruct, it becomes very difficult to find the nerve or the nerve ends, and in that case facial reanimation might be an alternative.
Yes. So sometimes we see that some people advocate to reconstruct, at least need to wait for some 6 months time, something like that.
No, if it is accidental, injury,
Right.
nothing like primary reconstruction.
Exactly.
As you said, if the ends can be approximated without tension,
Yes.
then approximation, otherwise a cable graft. And we don't have much experience with cable grafting and post-operative radiation, but reports say that it has not much of effect on the healing or the what do you call it, re-nervation of the gable graft.
Right, sir. Thank
I
you,
don't
sir.
know if others have any other experience regarding this.
Thank you, sir.
Thank you.
Thank you. Thank you. I have a quick, not a question. I just want to mention it. While I am in medical college, there is a question for postgraduate. It came as a what is the role of virus in head and neck tumors? So almost all the tumors have some role. Virus has some role in tumors of the head and neck. So I would like to know, is there any role of virus in salivary glands? Ashok?
Yes, yes, ma'am. There are a few.
Especially this is a time of coronavirus, na? That's why COVID-19.
Yes,
And
ma'am.
I would like to know that any role of virus.
Ma'am, as such, there is no documented virus association with salivary gland tumor, as far as literature says. But now there are, ma'am, lot of research going on salivary biomarkers. So even we are also part of 2SS research. So maybe, ma'am, because for cancer research, most of the focus is on virus etiology. Because if we can find virus as a cause, then we can produce some kind of preventive measures, some kind of vaccines and all. That's why so much of research on HPV vaccine or EBV vaccine, something like that. Ma'am.
Virus.
Yes, yes.
I
But,
think if there is some AP virus or human papilloma virus, or I think they have some also role in
all right,
tumors
right.
of salivary gland, particularly in Hodgkin's lymphoma or the lymphoma parotid.
Lymphoma group of, right, ma'am. Yes,
And the
yes.
research said that in HIV patient, in some cases, in HIV patient, Hodgkin lymphoma incidence is high. So there may be some relation. That's why I would like
In
to know
that
that.
group, yes, madam, you are correct. In that
Yeah,
group of patient, it is there.
yeah. And finally, because the technology is there, so is there any role of siloendoscopy in management of benign? I am saying that benign neoplasm of salivary gland. What is
Okay,
your
ma'am.
opinion?
Ma'am, we don't have that much of experience on that, but yes, there are people, there are papers also on this. There are sporadic reports. Lot of things are, because, ma'am, in recent times, parotid is one area. So focus of research has been now start shifting from thyroid to salivary glands, because at times there are a lot of research on thyroid. It might be situated now. Upcoming, there are a lot of new articles on salivary glands, as you rightly say, is related to viral etiology or other things like this.
Yes,
Yes,
yes.
ma'am, I totally agree with you. There are,
Yeah.
but we don't have
Thank
any
you.
experience or this thing, ma'am. Sorry. So,
Thank you.
yeah, yes, we have
Yeah.
our experienced people like Kalpana ma'am is there, and Fugan sir is there, Gautama is there. Can
Yeah.
provide some comment?
Somebody can
So,
highlight the role of endoscopy. Yeah, role siloendoscopy.
yeah. It is a very good presentation, Manas. But yes, definitely we don't have any experience with siloendoscopy. Am I audible?
Yes, ma'am.
Yes, you are audible.
Okay. But in case of repeated parotid abscess, the role of HIV, yes, definitely we need to rule out. That Madam has already pointed out. So if it is a case of repeated parotid abscess, we need to keep that in mind. One more important thing I want to highlight is that there may be some secondary deposits in the lymph glands within the salivary gland. And because of that, as Ahmed sir has pointed out, we need to go for the guided FNAC, which is very, very important to find out the pathology within the gland, within of a lymph node within the salivary gland. And that is important. These are the two things I wanted to just point it out. Otherwise, it is a very nice presentation. Thank you so much.
You very rightly says, even in Australia, metastatic lymph node from skin cancer like melanoma or squamous cell to the pre-parotid tumor more common than primary parotid tumor.
Exactly. The skin lesions going into the parotid is more common,
Yes,
squamous
yes.
cell carcinoma going to the parotid.
Yes.
But skin lesions, cancers in our part of the country is very uncommon.
Yes,
in
sir.
South India, it appears to, I think there are some reports from South India, skin cancer. But otherwise, in the rest of India, I don't know whether skin cancers are that common. Australia is very common because of their climate.
Climate
Maybe,
and
sir.
sun,
Yes.
sunshine.
Sun,
Yeah,
yes.
sun is very strong. Yeah. Mm.
So they have a lot of these actinic rays having an effect on the skin. And
Right.
other
In Australia,
diseases are
it
much
is
more
a
common.
more of basal cell carcinoma actually,
Basal cell
because they have got no pigment in the skin, and the ozone layer is
White
very
hair
less.
people.
Direct ultraviolet, they take sun bath, and ultraviolet they directly comes without any ozone layer in Australia, and particularly Antarctica also. Therefore, the basal cell carcinoma is more common there. But
Yes.
Manas had given just a comment to Manas, very nice presentation, because he was with me in MMC hospital for long days, very sincere boy. And actually, in the region of the lymph gland, of the intraparotid lymph nodes, lymphoid tissue, it is really interesting actually, as you have done many research. But the Manas has mentioned that Warthin's tumor, the HPV virus study should be there, as he has mentioned in his presentation. You were correct, but in literature it is given that both HPV and EB virus is responsible in some cases. I don't know about much thing about cancers because we have done more on pleomorphic, but you have to mention something about your surgical side, because it's a really interesting the parotid surgery. But otherwise, it is. But one last question I have asked: in older books, you see the pseudopodial extension of the parotid tumor for the recurrent extracapsular surgery. Is this theory still exists? Pseudopodial extension, Ashok?
Sir, even I was going to ask this thing to Amit sir and other all of you who has more experience than us. Have you, sir, ever been experienced any accessory parotid gland?
That is in WhatsApp is coming.
Accessory parotid, yes. I think I've come across only once.
Okay, okay.
And the other thing about pseudopodia, see, there was one, I forget where the report was or where the concept was put forward regarding the pseudopodia and the facial nerve relationship with the facial nerve.
Yes.
You see, because the parotid is encased in a fairly tight capsule, see, there is more compression lateromedially, that is in the plane of the facial nerve. When you see, most of these tumors are close to or abutting the facial nerve. But in this area, because of compression due to pressure, the pseudopodia probably cannot form because they are compressed by the pressure from outside and inside. But anterior, posteriorly, and superior inferiorly, it is probably not so because the tissues are comparatively looser and pseudopodia can occur in these areas. So that is one of the theories put forward
Yes, sir.
quite a long time back. I forget where it was. And with the in the clinical setting, probably we do a lot more of these adequate paroidectomies nowadays rather than complete formal superficial paroidectomies. And yes, I don't think we have got recurrences in the region of the facial nerve in any of the cases here. So that could be a reason.
Yes, sir. I think it's related to the capsule and exactly whatever you are saying, because it's a very tight compartment. That I think that is the proper explanation.
Mhm.
So, do we have any other questions or any comments?
So
We
any
can have
comment from other delegates or viewers?
Gautamda is there.
Can I make a comment, Dr. with your permission?
Yeah.
Yes,
Yeah.
yes.
Dr. Asukdas, can I make a comment with your
Yes,
permission?
yes. Dada,
And
yes.
since see, I am not you guys are experts on cancers. I am not a cancer person. So, but the topic was neoplasms. So
Yeah.
I wanted to just bring out 2 points. One point is regarding the use of silendoscopes. The use of silendoscopes is basically mainly for inflammatory lesions of the salivary glands, basically. Inflammatory lesions or stores. And sorry. And other point I wanted to make, there are sometimes intraoperative nodes which can also be due to tuberculosis. We had a
Okay.
presentation, a series of cases Vivek had presented in Kaziranga and Ipoh, actually, long time back. So you can often get intraoperative nodes which can be tuberculosis. That can confuse people. Thank you.
Thank you, Dada. Yes.
I think
Intraoperative nodes are more inflammatory than neoplastic. Mentioned, yes.
I think Ashok, the endoscopy, I find a reference. It is also used in cancer case also because through the duct they pass it, and through invasion of the duct like intercalated or the duct cancer, which are very dangerous and very burden to diagnose it. I've got one reference
for
I've seen,
diagnosis,
but I
yeah.
don't know the details.
Yes, yes, sir. Dr. Uttam Sinha, yes, sir. Dr. Uttam Sinha has done quite a lot of work. He is in California University, US. He was a ENT surgeon from West Bengal, a very close friend to Dr. Anil Recluse. That's why that's how I know him. I met him quite few times. He has a lot of works in salivary gland, particularly in this aspect. Sir. They have, yes, sir. There are reports and publications
I've
also.
seen reports, yes.
Yes, yes, sir.
Thank you.
So,
Thank you.
madam, do we have any more
Yeah.
point? But one last thing I would like to have. When we do parotid surgery, whether it is benign or malignant, we really sweat sometimes to find a nerve, and even we have experience seeing in even
Expired hand also.
workshop also. Even myself, I experienced once in Agartala. So I always strongly believe, and I used to tell our trainee also that facial nerve is always in its position. We are not reaching it. So whenever we are not getting the facial nerve during parotid surgery, we need to keep actually our nerve calm, and we need to reassure ourselves that nerve is there in its own position, but we are not reaching it. So we need not have to do hurry because of bleeding and other issues, because eventually nerve is there. Where nerve will go? So this is one thing I always remember in parotid surgery, that if for any reason, if I am not finding the nerve, I keep telling myself that nerve is there in its own position, but I am not reaching it. In that way, I think this is one tips I am benefited from this, and I just like to share with other my junior colleagues. And any other tips or surgical tips from experienced person like Amit sir? It will be beneficial for us.
Yeah, I think you're right, Ashok, regarding
Yeah.
the keeping your
He's
nerve
very right. Very
calm.
right. Hmm.
Acha, then another thing I'd like to say is, when we did our residency, the post-graduation, those days, surgery of parotid and thyroid used to be in the domain of general surgery. And ENT people
Yeah.
were, frowned upon, or,
Very
yeah, they were not only not encouraged, they were almost
discouraged, Dada.
very much discouraged. And Professor Anand probably was the first ENT person I know who started doing thyroids when we were doing our internship and house surgeonship in Dibrugarh. So that was the time we used to ask our teachers, in fact, that why is thyroid and parotid in general surgery when these structures are in the vicinity of ENT? So probably hearing that, Professor Arendata started doing thyroids,
Yes.
small thyroids to start with.
Now we
And
are head and neck surgeon, na? Not
yes,
only
now
ENT.
we are head and neck.
So head and neck is included. So all head and neck tumors are in our domain, right?
Yes,
Yes,
yes.
yes, yes.
Now the things have changed.
Yes.
Change.
And about identification of the facial nerve, it's still, sometimes it gives us a lot of sweat sometimes.
Yeah.
So probably the best thing that I have found, over the years is the old landmark of the tragal pointer. I think it still holds good, but another very important thing which we didn't come across in early days is the posterior belly of the digastric, the superior border of the posterior belly, where close to its attachment to the mastoid.
Yes, sir.
That is the area, you know, we should expose both these areas, the tragal pointer as well as the posterior belly of the digastric, and uh, as you close
Tympanomuscular suture.
to, the facial nerve just appears there only, in that corner between the two. So if we are, you know, if we do this a little slowly and like without breaking sweat, we'll always find the nerve there.
One trick would also would Kuduza have done many ISIS, many parodied with him. Actually, I always when there is bleeding, I told him you take adrenaline ball. Actually, it
Oh yes,
works.
yes.
Particularly when the vessel in the near the facial nerve. Another is the tympanomuscular suture. It's a very
That's another.
steady landmark.
Yes,
Very steady. But because second pointer, if you pull the here and there, the pointer will go from here, not 1 centimeter, 1 centimeter, but 0.5 centimeter in stylomus, sorry, tympanomuscular suture is very static pointer. Do you agree?
yes. The tympanomuscular suture, actually, more than the tympanomuscular suture, is the prominence of the tympanic bone, the inferior border of
That
the
is a yes,
tympanic bone,
tympanic bone.
and the medial extent of that. When you come to the medial extent of that, that is where the nerve is, within millimeters of that, the medial
Yes,
end of the tympanic bone ridge, and
there
that's
is a paper
very
also.
easy to palpate with your finger.
Yes, easy to palpate.
The suture may not be so
Hello.
easy, but the ridge is very easy to palpate. So
Yes.
whenever you're doing that, I think the finger again comes in handy there.
Correct.
Yes, sir. Hello. Good, sir.
Yes.
Yes.
Sir, sir, one question, sir, that before doing to suppose one malignant parotid case.
Parotid.
So what? Yeah, parotid. So what is the principles? Is the total removal of the disease or preserving the facial nerve?
Well, both.
Which one is
Both.
important?
Both are important. Uh,
Yeah.
as far as you can preserve
Yes.
the facial nerve, even if the tumor is abutting or apparently stuck to the facial nerve or any of its branches, and if you can slowly tease away the tumor from the nerve, reports say that there is no difference to the ultimate outcome if you save the nerve, even if the tumor is stuck to it. And
Another question, sir.
only if the tumor or the nerve goes through the tumor, then there's no option but to sacrifice it.
So another question, sir. So regarding the facial nerve, suppose should we take the separate one informed consent? So you can sacrifice or you may not be preserved before surgery, sir.
In parotid surgery, I think that facial nerve consent should always be taken.
Yeah.
Yes, yes,
Yes.
sir. Thank you, sir.
Sir, lastly, I would like to ask, what is your experience of using magnification in parotid surgery? How many of you use
Oh, yes.
magnification?
Yes. Magnification, I think, is important. And one thing about magnification, if you see, if you're a young surgeon, in your 30s or maybe earlier even, you may not feel the need for any magnification because you can see everything quite big. But as the years go along, you'll find that you're seeing a little less acutely than you used to see earlier. So magnification becomes important. So nowadays we always use magnification, at least a loop.
Yes.
We always use a loop, the minimum of a loop. And in certain cases, if the tumor or the tumor nerve interface becomes more difficult, the microscope can come in handy in such a case. And
So,
since
do
ENT
you
surgeon,
agree that a microscope gives a better for the interlacing connection between the different branches of the facial? Satish has shown, Satish Jain, all the fibers from the connection of one to another with the microscope. But he's a master of that with the doing that one with microscope. It's difficult to do with the microscope also for ourselves. But Vishwajit Gogoi can do. He does nicely with microscope, thyroid and this parotid because accustomed more, I think.
Right.
Because we are not accustomed.
Sir, we only use loop, but I don't have any experience of using microscope, sir. Yes.
Some people does not even want. They do not. They think the loop should also be have advantage. Young surgeons, I think, maybe.
it is young surgeons and those who have high myopia. You see, high myopia.
So only one thing. Yeah.
They can see. You see, myopics when they see through corrected lenses that they have high, say, diopter minus lenses. So with age, this myopia reduces.
Corrected.
And they come ultimately they come to a stage when they are doing something nearby or reading, they don't need the spectacles at all. So they think that they are seeing a magnified view of the surgical field.
Presbyopia comes here. And
That happens
fighting
with
with
one of my well-known friends who is a plastic surgeon, and he says that I don't need a microscope. My bare eyes are my microscope.
Yes. So, sir, we are almost running quite behind time, ma'am. I think we should end up here. Only thing is that whoever use magnification first time, so they should be little cautious about using cautery or bipolar near the nerve, because in magnified way sometimes we go very near the nerve. That is only. Thank you, madam. Thank you all for your all comments and all. So we end up this session.
Thank you so much.
I think.
Madam, should I close?
Yes. Yeah. You close it.
Yeah.
You end up. Yeah.
So first, I have to say this was a very successful and excellent webinar. And first, I have to congratulate Dr. Manas Pratim Das. Actually, he presented the subject. This is a very wide subject, and he very nicely and elaborately presented the subject, and he touched all the points from the diagnosis to the treatment. And secondly, I congratulate Professor Ashok Das as a moderator, and he nicely moderated the presentation. And thank you, Ashok, for
Thank you,
your
brother.
participation. And next, I have to give the thanks to my teachers, all the teachers, especially Kudus Ahmed sir. He nicely sharing his and very clearly all the queries, and his participations is a very grand one really today. And to the other teachers, my Sagata ma'am, Kalpana ma'am, Marcelda, and Gautam Das, and all. And they are sharing their knowledge very nicely, and we have learned too much things about salivary gland tumors. And last, I give the thanks to all the participants today to sparing their valuable time and encourage towards speakers and moderators and all the attendees. So thank you all. Good night, everybody.
Good night.